We would like to welcome to Immunity Group's podcast today a very interesting guest from Montreal, from Canada. We're speaking with a Canadian professor of allergy, Dr. Philippe Bégin, but he has so many hats and affiliations and interesting projects that I will let Dr. Philippe introduce himself. Welcome to our podcast.
Thank you, thank you. So I'm happy to be here. Well, so I do have lots of hats, but essentially I'm primarily an allergist, and my favorite thing to do is treat food allergy. On this side, I'm also a researcher, so doing research on developing new treatments and also looking at the science of how we can implement stuff that we find works on the scientific side and try to make it work in real life so everyone has access to it.
How
Because
did you
that's
get
one of the
interested
biggest challenge.
in food allergies? Do you have food allergies yourself, or how did you choose this particular field of medicine?
Yeah, I mean, it's kind of random, I guess. So I did rotation when I was a medical student. I liked allergies. Then once I was an allergy resident, what I liked the most was food allergy, because there's a big part of it, which is just talking with the people to understand, what's causing the reaction. And back then we really had nothing to offer patients. So it's basically, here's the auto injector, and we'll see you again in 2 years and hope you don't have an accident, and that's it. And back then when I was training, there was oral therapy that was starting to appear in different places. So after I finished training, I went 2 years in Stanford with Coronado, and I spent 2 years doing research on oral immunotherapy and on how to treat patients with multiple severe food allergies. So when I got back to Montreal, that was my focus, like opening an oral immunotherapy clinic where we could treat patients.
This is beautiful. I mean, Professor Nadeau has so many books about it as well, and in Australia, a lot of families with food allergies love the latest book with a sandwich and peanut butter sandwich and the blue cover. That's fascinating. So that translational knowledge sharing was crucial then to bring that new expertise with you to Canada.
Yeah, I mean, there's the scientific aspect of it, obviously, but one thing I saw there was really the dynamic between the parent groups and Dr. Nadeau. And I really, there's this concept of social entrepreneurship. So I mean, there's an entrepreneurship, culture in the Bay Area. But when I came back, what I brought back was this concept of social entrepreneurship. So you need to develop something, but on the public side, so everyone can enjoy the treatment later. And when I came back, I saw all these patients that were just looking for a way to organize themselves. They wanted to help. They could see that there was a treatment available, something that worked. And people were telling me, I've always accepted my food allergy because there was no treatment. But now that I know that there's a treatment, I can't accept that my child is not getting it. So now I want to do everything that's possible. So we change things. And I understand it takes time, but can we do something so it changes faster? So I started just responding to the patients, and they created this group, which they called Bye Bye Allergy, started raising money. So we wrote this business case that I presented to the hospital back then. And they said, well, okay, you convinced us that it's a nice project, and we will let you do it if you raise enough for 3 years of activity. So that was $750,000. So the
Wow.
parents say,
So how
well,
does analogies do that? How
so
do you do that?
so I didn't do it. The patients did it. So it took 3 years, and that was, the biggest fundraiser of the hospital. They've raised much more money than that in other fundraisers, but there was always corporate involved. Here, there was no corporation. It was just individuals giving 20, giving 100, and usually like this. So, and they did reach the $750,000. In parallel, we were working with the government, letting them know what we were developing. And when we reached 750,000, at the same time, the ministry called, said, well, this is a nice project, so we're going to match it, and it's going to be a public OIT clinic, so you can use the extra money, because now we have double what you technically need for development and for knowledge translation. And one thing that he said was, however, obviously this is a pilot, so you can't treat everyone. So I want you to have criteria to select patients, select the most severe patients. So this is something that's a bit different from other places in the world where people tend to start with the lowest hanging fruits. So patients that are not too allergic, you sensitize, it goes well, and then you start moving on to the harder cases. We actually started with the most severe cases. So it's interesting because we developed a special kind of expertise here in Montreal, treating the severe cases, dealing with some complications that we might have had more often than other, using some medications that other typically don't use as often also. But all this is great because it's trickling down to all the residents that are coming in, seeing this. So when they go and practice, for the practicing allergists, OIT is a new thing. For them, it's just the norm. It's the standard. It's normal to do OIT, and the normal patient is going to be less severe than the one they actually treated that's interested in. So it's easy for them to start doing OIT. Well, easy. I mean, there's always the infrastructure, and you need support, and there's always limitations. But for them, individually, they don't have personal limitation in offering OIT to their patients.
So when it came to talking to your colleagues after your Stanford residence, what kind of feedback immediately did you encounter? How did you make or create this critical mass of colleagues before you presented the case to the government and other stakeholders?
Yeah, so my immediate colleagues, I mean, I work with them every day. So, they could see me desensitize patients and severe patients and see that it works. So they were very, very easy to convince. The problem back then, that was in 2014, was that the official message out there was that oral immunotherapy didn't work. That was, people said it was off-label, which is technically not possible since it's not a medication. It can't be off-label. So people were, and as a doctor, you have this healthy skepticism toward everything that you see published, because, it's never exactly the same thing when you start doing it in practice. So I did have to face this skepticism with colleagues, but some colleagues were more open than others. I would say the pediatric colleagues could see the need, and they were more aware of oral therapy. So my message to them initially was really just, start with the low-hanging fruit. Start with one family that is easy to talk to. They're not complicated. They will understand that you're developing something new. So nice people, and not a severe allergy, because people all want to go with their most severe case because he really needs it or she really needs it. But don't do that to start. Just do an easy case, and then once you do this, you'll see that it's actually really easy and it works. And then you can move on to other patients, and that's pretty much what happens. So my colleagues that did start a few patients, then they developed their own expertise, and now they're comfortable doing oral immunotherapy on their own. So they only call me or we discuss complicated cases, complex cases in video conference that we organize, or just phone calls. But they're mostly able to do those cases on their own. Now, we also have our own OIT clinic here, which focuses on the severe cases where allergists can refer. But we had so many patients. I mean, we had a waiting list of 2,500 patients, and it just doesn't go down because there's more people coming in than we managed to treat. And that was one of my frustrations. You do this research, you find this treatment that works, but you can't get patients to have access to it. So it's not just doing the research. I kind of had to, learn on the spot how to do this other kind of research, was this implementation research. How do you develop systems where patients can access? How can you rethink care? Because in the US, there are lots of allergists. In Canada, we have an issue, and I think you have the same issue in Australia, that there's not that many allergists for the population. It's a huge territory. And the mentality is, the culture is that I have an allergy, I need an allergist. 30% of the population has allergies. And we're only 70 allergists in the province of Quebec for 8 million people. So how does that make sense? If I have diabetes, I don't need an endocrinologist. My family doctor will treat my diabetes. If there's complications, I'll see the endocrinologist. But for allergies, you also always need to see an allergist. So the waiting list for allergy is huge, full of stuff that maybe you don't need a specialist for. And then you see all these young kids that develop, they're 7 months old and develop their allergy. It's going to take 3 years for them to see an allergist. By that time, you missed the window to cure them. So it was extremely, frustrating as a doctor to see this, and even if I wanted to see them all, I can't. So you need to rethink the system and look for alternative solutions to just see an allergist. So this is stuff that we're working on.
I think it's quite similar in the UK, where the GPs are now being trained to just be also more familiar with allergies, because they are the first patient point of contact. I mean, as a food allergy mom myself, I saw more than 7 allergists in Australia, more than 5 in Serbia, before we found the option across in the United States and brought the method with Dr. Jones to Australia. So patient-led grassroots initiatives definitely work. When it comes to the French-speaking world, I think that is the most fascinating part for me from our previous discussion. Barriers which exist probably in the Anglophone world are different in the Francophone world. So how did you deal with that? Literature, scientific literature in French and in the French-speaking world, was there much difference? And also I know that in France, there are actually OIT clinics in Lille and in other places now growing. So is it different from a Francophone lens?
Yeah, so there was a big difference because, well, from a scientific point of view, there's no difference because we follow the same literature. We follow the English literature. We write our scientific papers in English also. So that's not the issue. But the culture, the whole question of whether it was ready for clinical practice or should remain in research, that was a huge issue, especially in the US. And people were very, very polarized on this issue. So you had people that said it was ready for clinical practice, and then people say it was malpractice to do OIT because it should be in research, and other people said, well, you can't do it because you don't have an FDA-approved product to do it, and it should only be done with a drug. So it was hard to be open about saying I want to start OIT without triggering all these hostile discussions. The language barrier kind of protected me against this. You could actually sit, talk with colleagues, talk with politicians, talk with patients, and just have a normal discussions talking about the limits. We don't know this, we don't know that, but we do know this and that. So we can start moving forward. And so the prime minister, the health minister, when he made the announcement for the clinic, he actually said, and he's a radiologist, so he's a doctor. He got it. He said, we cannot say that oral immunotherapy is 100%, indicated right now, or that was in 2017. But there is no question that it will be eventually. We're working, and it would not be responsible as a minister for me not to support this group. So we're ready when it is prime time, and we're able to give it to everyone. If you wait to have all the answers, well, when you start, you're going to have 10 years. You're going to be 10 years behind when you want to start offering it.
So when you
So this
started,
is,
you were offering multi-food from the beginning.
yes, from the beginning, because that's how I trained. Those were the research projects that we did. So we would desensitize up to 5, 6, or sometimes 7 foods at the same time. And we would focus on the severe patients. So, most of our patients were multi-food allergic patients. So it makes no sense to sensitize just one food. Well, sometimes it does, but most of the time it doesn't make sense. You want to treat everything, or at least all the significant foods for the patient.
And there is this so-called peanut privilege in the food allergy world, where product development is really focused on that peanut privilege, whereas the majority of food allergy patients have other allergies. How do you see this peanut privilege in this world?
It's really interesting you bring it up, because I didn't know that word. But the concept I'm very, very familiar with. And the most obvious, thing is just research. So most of the clinical trials are done for peanut allergy. And is there a reason why what we develop and show that works with peanut wouldn't work for other foods? We also have trials for OIT for milk, for egg, for nuts, and they all work in the same way. Biologically, it's the same. But then you have the product that was being developed in the United States, which was by Palforzia back then. So you had this this position that OIT should be done with an FDA approved product. So, but when you think about it, you say, okay, well, even if I accept this, that we need phase 3 trials to put it on the markets, and then we have PS, what this implies is that then we're going to need to do that for milk and egg. And when are we going to do that for my buckwheat allergic patients, for the flaxseed allergic patients? We're never going to have 300 patient trials for these. It makes no sense. So there's a justice issue here. You can't just say we're going to treat these foods and not the others. So when we wrote the Canadian guidelines on oral therapy, those were published in 2020. But we worked with a government agency who were working on an alternative way to write guidelines. So it's not that we're not looking at science. We're looking at science the same way that you usually when you write clinical guidelines, but we incorporate other considerations. So social consideration, environmental, political, and also ethical considerations when we make the analysis of the problem, and then when we come up with the recommendations. So that's how we came up with the recommendations in 2020 that, OIT should be regarded as equal for all the different foods. The recommendations should be regarded as, applying to all the different foods, unless there's a specific reason, otherwise. So that solves the issue of access. There's no reason, someone that's allergic to potato, that's really, really, really rare, but that really, really, really sucks because potatoes, it's everywhere. So we were able to desensitize our potato allergic patients. So that's kind of the idea. And I really can't think of any other disease or treatment in medicine that's like this. It's very unique for allergy because of the food versus drug aspect to it, because it's always around you, but you're not actually sick if you're not eating the food. So the implications when you give the treatment is not as obvious as a disease. Hypertension, you can see the hypertension come down. It's unique. So we have to rethink the way we develop products and service to the population and put it in practice.
As a political scientist, I find your concept of justice in the new guidelines absolutely fascinating. And you mentioned before in our preparation for the interview that whole concept of natural justice. Would you mind explaining it a little bit further, please?
Yeah, so in medicine we have four ethical pillars. So there's benevolence, so you want to do good. Non-malfeasance, you don't want to do harm. There's autonomy, you need to respect what the patient wants. And then the last pillar is justice. You need to be fair in the way you distribute care, because you can't do everything for everyone. Interestingly, in the United States, that fourth pillar is different. They call it civil rights. So you can't treat patients differently based on their color, but obviously in the purely private system like they have, you can't talk about fairness. But in a public system, we do have this issue with fairness. So it's not because you live very far from the city that you shouldn't be getting the same care as someone that lives in the city. It's not because you're allergic to a rare food that you shouldn't be getting the treatment or the opportunities that the patients with the mainstream food like peanut is able to get. And obviously there's the money issue. It's not because you have money that you should have access to better care than someone that doesn't have a job or has a job that pays less. So when you make recommendations, you need to take this into considerations. So obviously, people say, oh, you don't like Palforzia, but it's a standardized product. Are you against standardized product? How can you be against standardized product? I'm not against standardized product. My question is that standardization worth $50,000 per year? Does it justify that cost for my patients? And the recommendations, the guidelines is not don't use standardized product or proprietary product. It's you need to take into consideration the overall costs. If it becomes a barrier to care, then maybe it's not worth it. So when you look at it, I can offer OIT for $7 a year worth of peanut or $50,000 worth. I mean, obviously, this is a huge barrier. It doesn't make sense to me and to many people. So that's why we developed it outside the pharmacological world. Yeah.
When it comes to the psychosocial aspect of OIT families, how does in Quebec, how do different teams manage that? Because the psychosocial aspect often, that mental health resilience of the families is so important.
Yeah. When I was writing up the business plan for our clinic, I was talking with a manager in the hospital and explaining to her that, the cost of food allergy doesn't come from the reactions. They're actually rare and they don't cost that much to the system in direct health costs. The cost is really this intangible cost of the impact on your quality of life, the fact that you're always worried about a potential reaction, the social limitations. And then she says, oh, but wouldn't it be cheaper just to pay for psychological support? So when she said that, I said, well, if I had a cure for blindness, we just say, well, it costs too much. We're just going to pay psychologists to tell the blind people to live with it. So then she said, oh yeah, that was kind of dumb. And I said, yes, it was. And then we moved on. So, but that's the issue. So with food allergy, the big impact is really on your quality of life. And that was the reason there was no investment in food allergy before, because pharmaceutical company could not see where you were making. They wanted to fund asthma research because, see, asthma, we're throwing money at it. So it's easy to say, if I have this new drug, well, you're going to save that much money, so it justifies this high price with my drug. With food allergy, it costs nothing to the system. So they say, why would I invest there? I'm not going to get. Now it's much more obvious that there is a high willingness to pay for food allergy treatment, and now pharmaceutical companies are interested in that area. But 10 years ago, 15 years ago, there was really not that much interest. So we needed to document this impact, and it was hard at first because the way that the government speaks is really with numbers. So you actually need to quantify the impact on quality of life. So that was part of the research I started doing, which I had no training on before, but I just trained on the spot to do this research, to create these tools where we could actually quantify the impact on quality of life. So the way you do this is questionnaires with families, where you have them compare different situations. Say, would you rather live 10 years in this condition, or 7 years with full health? So, well, I choose this situation or that situation. So then you can equate that. Okay, so you'd rather lose 30% of your lifetime than have this condition. So basically, this costs 30% of your quality of life. We kind of do these equations. So another way to do it is, I have this treatment for peanut, but there's 5% chance it will kill you instantly. Do you take it? So if people say, yes, I take it, but it's going to cure my peanut allergy, you can say that, well, the impact is 5%. So you can imagine how it. So we did all these studies, and we were able to quantify this impact. So I'm able to go to the government and say, this is the cost per what we call quality adjusted life here. So when I actually went to the government and I told them, so here is my cost, it's between $500 and $2,500 per quality adjusted life here. The guy, it wasn't a minister, it was another guy, but he drops his pen and all his staff in the back start laughing. I say, why aren't you just doing it? Because usually, anything below $50,000 for them, it's a no-brainer. You should just do it. He says, well, if I was an oncologist and I was giving chemotherapy and I had this new great chemotherapy, I'd stop giving the first one, which costs an arm and a leg, and I'd use that money to pay the new one. The problem is that I have no treatment and there is absolutely no funding for food allergy. So we're starting from scratch. So even if it doesn't cost a lot, it's still a new investment that needs to be made. Hence the reason why I'm talking to you, when I'm talking to the government. But those numbers were really key to talking their language. Now, to communicate that the impact to the greater public, that was tricky, because some people said, well, you have more reactions if you do OIT than if you don't. So basically, patients, your challenges you're doing research, those are not patient-oriented outcome. You need patient-oriented outcome, and reactions, that's what patients care about. So therefore, OIT is bad. And that was something that was being said by allergists that had peanut allergy. So when they were saying this, they were saying, well, I represent patients with peanut allergy because I have peanut allergy. The thing is, an allergist with a peanut allergy is not the same thing as a patient with a peanut allergy. As an allergist, I can assess the exact risk of everything I do. When I speak about my peanut allergy, I have authority and people will respect what I say. When I'm a patient that's new to this, I don't know. I can't evaluate the risk. So there's this constant uncertainty around me. When I speak about it, people don't take me seriously. People don't listen to me. My parents are not going to do what they need to do with my kid. They're still going to give the food or not care properly. So I'm always living with that fear. So it's a completely different situation. With OIT, you have to eat the food. So that's very stressful the moment you eat the food, especially at first. But you know you're eating the food. Initially, you're doing it at the hospital, and when you're doing it at home, your parents are looking at you and you wait for an hour. But then for the rest of the day, if I'm eating one peanut every day, for the three other hours of the day, I really don't need to worry. So yes, that 1 hour can be worrisome, and yes, I can have reactions, but actually I'm free for the rest of the day. And this is where patients get their impact. But actually, not only this, because you're actually eating the food and you are having those reactions that you would probably never would have had before. And what you do when you have the reactions, you treat them. So now you're learning actually what my reactions are like. So I'm learning to recognize my reactions. I'm learning that the treatment works, and I'm able to manage it myself. So I went from this naive patients to this expert patients, which is basically like my colleague with peanut allergy that can live with their peanut allergy. So I have some patients that stopped OIT because it was too complicated. They hated the food. They had too many side effects, whatever the reasons. At the end, I say, oh, well, that sucks. I mean, you spent 1 year, 2 years, and now it's, down the drain. And I said, oh, no, 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 no. If I had to do it all over again, I would still do it because I'm not the same person now that I was back then. Everything I learned, that's what makes me able not to have oral immunotherapy now. So this is the impact on quality of life.
I will share a story with you. So last week we were in Fiji as a family, and my daughter finished OIT for milk and egg. She graduated milk recently, about a month ago. And in Fiji, 33 degrees. She was having a cheese pizza with a new friend. I left her alone. I come back after 10 minutes. She got some hives because she was putting cheese pizza on her face. And I said, what did you do? She took her own antihistamine. We're talking about a 9-year-old child. I was super impressed. Obviously, we moved into a cooler area, but a 9-year-old child who used to be contact reactive, more than 15 hospitalizations in the past, to actually manage a very minor skin reaction after eating an entire cheese pizza was unbelievable in terms of her confidence to do that by herself was unbelievable. I'm super
It's
impressed.
it's great you're taking it this way, because some patients with teenagers, there's some parents with teenagers have a hard time actually accepting that the patient knows what he's doing. So this is something mostly prior to YT, but I do see it in YT also. So I had lots of, because I also see adults, so young adults or older teenagers, and they would tell me that they would fight with their parents between, they eat the food by accident, they have these mild reactions, and the parents would go crazy, say, take your epi now. Says, well, no, I don't need my epi because I know my symptoms. I've had those reactions before. And the parents don't listen and don't take into consideration their experiential knowledge. They've lived those reactions. And science shows that, between individuals, reactions are very different, but within the same individual, it's usually the same symptoms that come. So once you've had lots of reaction, you actually learn, and you can tell usually which way it's going. And if you're in doubt, obviously give your epinephrine. But those patients, like, you need to respect that knowledge. They know. And with OIT, you're actually gaining that knowledge also. So I let patients manage take their own decisions a lot. That's my internal medicine side, because I also deal a lot with adults, so we're less paternalistic, and ultimately, it all comes down to a question of tolerance to risk. And some doctors have no tolerance to risk, but you shouldn't impose that to your patient. If the patient is willing to take that risk because it opens possibilities to them, let them. It's their decision. And so what if they die? If I'm going on vacation in Fiji and I decide to go, diving, and the equipment doesn't look that great, but I decide to do it anyway because I'm on vacation, I want to do it, and I have an accident and I die. That was a self-made decision. I took that risk. I went hiking in the mountains with my brother. I took that risk. I could have died, but I still went. So there's this aspect that we need to be open about with our patients. It's all about risk management, and that's why also I don't push patients to stay on their food for life. If they like the food, that's great. But after they've done 3 years of OIT on the adult side, so the kids, usually the parents won't let them stop. On the adult side, after 3 years, especially for nuts and peanuts, is I'm so fed up with a peanut. They're disgusting. When I started OIT, I thought they were going to be great, but I realized they're not. So I'm thinking of stopping. So I thought, well, we're going to stop. So because if I don't, they're going to stop anyway. So but I'm going to have you come back in 3 months and we'll do a challenge, not to 50 peanuts like in the studies, just to one peanut. And almost all patients, sometimes some of the symptoms will come back because they don't eat it every day in the mouth, in the stomach. But because they've developed the protective antibodies, which is in the bloodstream, they don't have anaphylaxis anymore. The moment the small amount of peanut enters the bloodstream, it's neutralized by the protective antibodies, and they're not anaphylactic anymore. So you tell me it's great. I have the best of two worlds. I don't need to eat peanuts, but now I can travel. I can kiss without asking the person, did you eat peanut before? Share drinks, all this. And if ever there was an accident, there was peanut there, I would feel it in my mouth, but worst case scenario, I wouldn't have anaphylaxis. So this is great. And
Cross-contamination is such a
yeah,
huge, safety is such a huge benefit, the
absolutely.
quality of life. And what would you say to those parents who would love their children to be safe through oral immunotherapy, but themselves are very scared? How would you encourage those parents to proceed?
Yeah, I mean, it is scary at first. A lot of the parents, some people they say, oh, we shouldn't care about the parents. In pediatrics, there's this focus on the child, and it's a good thing because historically pediatrics have been mostly, you talk about the parents, you take the decision, you don't take into consideration the child, but you don't want to go all the other side either. Some of the patients, when you treat their child, I remember one that was when I was in the US. This dad would not talk, never. He would just sit in the corner during the visits, and he was just a very introverted person. But then after 1 year, when we finally graduated, he came and he was crying. He took me in his arms. Oh my God, I didn't expect that at all. And then he started talking. He started telling me that, he remembers taking his daughter when she was 1 or 2, and she was blue and she was flaccid, and he brought her to the ER and said, please save my child. And he'd been having these dreams since, thinking about this again and again. So, I mean, he had all the criteria for PTSD, post-traumatic stress disorder. So we can't, minimize the impact on the quality of life. They almost lost their child. So this, a lot of those reactions. And even if you objectively weren't there, doesn't matter. The way you felt it was that they were dying and potentially close to dying. So you need to take that into account. So if you have this, obviously doing the OIT is going to be very hard. So you have to acknowledge this and just talk about it. And some patients will need to have some psychiatrist, psychologic support. So we did send some families to psychologists, the hospital psychologists initially. It's a public center, so we don't have, we can't send everyone. But then she came back to us and says, well, how do you choose those patients? Those patients have all these red flags that you shouldn't have started treatment in them. But then we explain, yeah, but all those red flags you're talking about also make it hard to deal with the food allergy, the anxiety, and says, oh yeah, I understand. So, and what you really would need would be a social worker for these patients, because oftentimes people don't realize it, but before entering in the process of oral immunotherapy, this is going to be stressful. You need to make sure you're in the perfect situation. So there's stuff you can't change. If you have anxiety disorder, well, you can treat it, but there's so much you can do. But if you're in between jobs, if you just got separated, if you have another child with an acute or chronic disease that you need to be managing right now, those are all stressors which add up, which make that maybe this is not the best time to be doing OIT, because it will be stressful. If we're talking about a 1-year-old that just became allergic, I would push a bit more for us to do it anyway, because I know there's a window. We don't want to miss it. And usually it's going to be easy. So I can reassure patients that when we intervene really early, those are usually easy OIT. But if you're an older child or an adolescent or an adult, there's no rush. It's still going to work just as well if we do it in 2 years as if we do it now. So you really need to take into consideration: is it the best time in my life to do this? And the other thing that I tell people is that when you sign the contract, it's not really a contract. The contract is that you're going to keep doing this and you're going to call us if there's a problem. That's the big contract. You can stop whenever you want. So you are allowed to change your mind, because you have this idea of what OIT is, but when you start doing it, it might not be what you had in mind. And your objective can change also. Maybe your objective right now is to eat 20 peanuts. Yeah, but that's because your friend loves peanut butter and you have this idea that it's great. my first patient is sensitized to tahini. Back then, it was the first patient. We didn't know you need to use tahini and not whole sesame. So we actually use sesame seeds, which don't work that well to desensitize. But whatever. At some point, we switched to tahini. And when she tasted it, she was coming from Toronto, so it's a 6-hour drive that she would do every other week for her desensitization. And she did that for 6 months until we switched to tahini. And her motivation to do this was every morning when she would wake up, she'd see her dad eat tahini on crackers and tell her this is the best thing in the world. When she actually tasted the tahini, she started yelling at us, "I can't believe you made me thought this actually tasted good." And the poor guy was completely like, he didn't understand because he actually thought it was good. In my head, I was like, well, that was kind of expected. But anyway, so she learned that she didn't like tahini. So obviously her objective changed. So her objective was not to eat tahini crackers every day. It was just like base protection is way enough for her. So you're allowed to change your mind. Obviously your objective is not going to be the same for milk that it is for nuts. Also, usually milk, people want to be able to eat it, but most patients allergic to milk find milk absolutely disgusting when they drink it. So oftentimes we're going to switch to string cheese. And bring the dose up with the cheese because that actually opens possibilities. But everyone's different. So I have my students tell me what your objective is and we'll adjust. On the adult side, I do a lot of cofactor challenges. So for example, this patient that's allergic to milk and would get lots of reactions when he do sports or take alcohols. We've done it for a while and he wants to know, well, the issue now is that I have this work and we go on Thursday nights with everyone at work and we have pizza and beer. Can I have beer with my pizza? So I said, well, just come here. We'll take your beer and take your slice of pizza and we'll wait for an hour. And he didn't react. So I said, yay, that's great. So now I can have beer with pizza because, usually you don't combine alcohol with your food when you're desensitizing. And then he called a month later and said, yeah, doctor, the thing is, you know how we said 1 beer and 1 pizza? It's actually more like 2 beers and 2 slices of pizza. So I just had him come back in and we did 2 slices of pizzas with 2 beers and he was fine
Love
again.
that.
So,
That's
but
beautiful.
we don't do that for all patients, but for him, that was the question. So we did that.
I absolutely love that. It's such a good example of real life and real life challenges in social situations, which are usually the most challenging for all food allergy individuals and families. Professor Bégin, there is so much that we can talk, but I would like to leave it perhaps for 2025. We would love to have you back on our podcast
It was
and
my pleasure.
share some more amazing stories.
For sure.
Thank you so much, and we look forward to speaking with you in the future again.
Thank you. And happy holidays and a happy new year.
Happy New Year.